Okay, my name's Jamie. As the title slide says, I'm a cardiology registrar within Thames Valley, currently working in Oxford, and I'm British Heart Foundation Clinical Research Fellow. What I'm aiming to do with this talk is try to reacquaint you with ECGs if you haven't looked at them for a while, simplify the approach looking at any ECG which may seem scary, so that anything that's thrown in front of you you can deal with, and hopefully update you if you haven't done ALS recently of what the latest guideline says around managing some of the ECGs we'll be looking at. So I will make a start. I'd just like to make a couple of acknowledgements. Many of the ECGs for this talk came from a consultant colleague of mine, Nick Sabawal, so I'd like to thank him. And I noticed a typo there, Research Council rather than Council, kindly provided their algorithms, which we'll be referring to as we go. I have no disclosures other than I'm funded by the British Heart Foundation. So what we're going to cover today, I'm afraid we do have to go back a little bit to the cardiac physiology. I promise I'll keep this part short. And we will look at the basics of cardiac conduction. We'll then go on to look at slow heart rhythms and fast heart rhythms, a recap of common antiarrhythmics that you may not have used for a while, and the practicalities of using these in ED and acute medicine, where most of you will be hopefully working again. Acute coronary syndromes, which have many names, NSTEMI and STEMI, most people are familiar with, now called NSTACS and STACS, and many other names in between. Then there's a little quiz, which we'll try and work if the technology allows, followed by a summary slide, and then time for questions at the end. The panelists, other than myself speaking, will be collating the questions as we go, so that you can put them to me at the end. It'll be quite hard to interrupt throughout with lots and lots of you on the webinar. So, first slide, basics of cardiac conduction. So if you remember, the electricity in the heart comes from the top right, in the right atrium, from a little Duracell battery equivalent called the sinoatrial node. And as the diagram shows, it flows to the AV node, which is a bit like a goalkeeper. And what that's doing is making sure that the signals in the atrium don't go too fast to the ventricles. So it's a sort of safety net or buffer. In the vast majority of individuals, electricity can't pass any other way. Essentially, the groove that runs between the atrium and the ventricles in your heart acts like a firewall. It's insulated. A very small proportion of people do have gaps in this, called accessory pathways. The one that everyone seems to remember from med school is Wolff-Parkinson-White, and we will touch on that a bit later. After the AV node, the electricity passes down through the Purkinje fibers and the bundles of His into the left and right ventricles respectively. And it's this electrical pathway which makes up your ECG. The electricity going from the sinoatrial node to the AV node is your PR interval. The QRS is made of the time from the AV node down to the ventricles. And the ventricular repolarization, or the heart's recovery, is the T wave. And that's what we're seeing here. The P, the QRS, and the T, and here in this particular ECG you'll see ST depression. Some people get confused about what the J point is, so I thought I'd just put that in. Essentially it's the point where the S wave ends and the ST segment begins. It's not relevant to the vast majority, but particularly in some rare conditions it's quite important, and I'll point that out when the ECG of note comes up later on. So my simple approach to ECG is largely pretty much what they teach you on ALS or ILS course. I think it's the right approach, and to simplify it down to 5 key questions. Is the rhythm fast or slow? And the different guidelines can tell you what a tachycardia and bradycardia are, but roughly is it more than 90, less than 55? And there's 2 ways of doing this, and we'll look at this on the ECGs as we come across them. Essentially, you can count the number of complexes, R waves, and then times it by 6. And that's particularly useful if the heart rate's irregular. If the heart rate is regular, then the alternative is to look at the number of large squares between the RR interval and then divide it. So for example, if there are 2 large squares between each RR interval, the heart rate's 150. The next key question is the QRS regular or irregular? The next one is the QRS narrow or broad, i.e. is the problem above the AV node or junctional at the level of the AV node, or is it below where it's broad? Is it within the ventricular conduction system? The next is, are there P waves? And if so, are the P waves associated with every QRS and in a regular pattern, or are they not associated, or do they lengthen? That will help us answer the question of what the rhythm actually is. So if you take these 5 questions and apply it to every ECG, you will be able to get 99.9% of ECGs. So we'll start with an ECG, and I've been deliberately harsh and I've removed the squares. But you take my word for it.
Jamie.
Okay. So here, I hope you'll all agree that it's regular. If you're not sure, the easiest way is to get a blank sheet of paper, mark out a couple of the RR intervals, slide that sheet of paper along, and if they all line up, you'll know it's regular. The rate here is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 times 6, it's 72. The QRS is narrow. The next question is, are there P waves? Yes. Are there P waves with every QRS? Yes, there's 1 for every QRS. So we have a nice, simple ECG here, tennis rhythm. And not all going to be as simple as that one. So we're going to start with bradyarrhythmias. I'm going to put up the ALS algorithm to start. If you've not been in practice for a while, I think the algorithm is excellent. They always say to use A, B, C, D, E. And if you start with this approach, you'll not miss a lot. So you approach your patient. If they're talking back to you, you know they're always patent. You do a rapid assessment of B, C, D, and E. And we will do a separate session on these in more detail, so I'm not going to go through that aspect today. But I wanted to highlight the key features, which are the same for either a slow or fast heart rhythm, so brady and tachy. And that is the patient shocked, i.e. are they peripherally shut down? Is their capillary refill time prolonged between 3 to 5 seconds or more? Is their blood pressure low? Have they presented with a blackout, or are they continuing to black out in the emergency department? Do they have ongoing chest pain while you're talking to them that sounds cardiac? And do they have signs of heart failure? JVP elevation, crackles in their lungs, peripheral leg swelling. All of these are the adverse features. And in the case of a bradyarrhythmia, you would move rapidly on to putting the pads on, and whilst the nurse is drawing at the atropine, you would also be asking for some extra help. And you can give the atropine in 500 mic aliquots up to a maximum of 3 grams. But if you've got someone in this particular category, you're looking to move rapidly on towards transcutaneous pacing. And again, I'm happy to run another session on that. I won't talk on that today. Those at the highest risk, if they don't have the adverse features, are these particular ECG findings, so complete heart block, a pause on the ECG between the RRs of more than 3 seconds, Mobitz type 2, or a period of asystole. So the first ECG, the people who are eagle-eyed will actually spot that the overall rate isn't actually following the definition of bradycardia, but it's illustrating a particular type of bradycardia that we see, and that people with this particular ECG, the rate will vary. So here, if we take that approach, I said, the 5-step approach. So the rate, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, times 6, it's 72. So it's not actually slow at this point. Is it regular or irregular? Well, these are certainly regular, just over 3 large, small squares between them. Then there's a pause with a longer period, and then it returns to that rhythm again, and the same happens. So we'll park that for now and come back to it. Is the QRS narrow or broad? It's narrow. So the next question is, are there P waves? There certainly are. And are there P waves with every QRS? Well, let's have a look. P wave here, P wave here, P wave here. But I hope I can convince you that the P wave is lengthening. Here it's about 3 small squares, which is normal. Remember, the upper limit of normal is 5 small squares or 200 milliseconds. And here we're approaching almost 10. And on the next beat, you drop your QRS. There's a P wave buried into the T, and then no QRS. And then the PR interval is shortened again, continually lengthens, and then we drop. And this is Wenke backing or Mobitz type 1. It's known as both, and it's seen very commonly. Lots of elite athletes will have this on a 24-hour holter. It's a sign of very, very high cardiovascular fitness and a very slick AV node. It's not always pathological and doesn't need pacing. Next rhythm, I'd hope you'd all be a little bit more worried about. So let's take the same approach again. What's the rate? 1, 2, 3, 4, 5, 6. times 6 are around 36. So it's fairly slow. Is it regular? If you're not sure, again, use the paper approach, remember out the RR intervals and move it along. Take my word for it, it is. Here is a fixed RR interval. Is the QRS narrow or broad? QRS is narrow. Are there P waves? There are P waves. Not the most convincing, but there are a couple scattered throughout. So is complete heart block. The P waves are not associated with the QRS, i.e. there's complete AV dissociation. And this is a ventricular escape rhythm. Because it's a narrowish complex, you know it's high just below the AV node. So it's almost called a junctional escape rhythm rather than a true ventricular where it would be a broader QRS. And most people will have this protective mechanism, and it depends on the rate at which your mechanism will have as to whether or not you black out or develop the adverse features on that ALS algorithm. So just to remind you what the indications for pacing are, the most important, if you're going to be working, coming back to practice, will be the acute ones. So acute third degree or complete heart block, like we just saw. Mobitz type 2, where there's 2 or 3 P waves for every QRS, or there's been a period of ventricular standstill, i.e. like we just said, 3 seconds with no ventricular activity. You don't need to pace or put a temporary wire in people with bifascicular or trifascicular block, i.e. a prolonged PR interval, a broadened QRS, and an abnormal axis. The chronic symptomatic disease is something you'll be dealing less with, so I won't touch on that too much now. So would you refer this for pacing? Let's take our stepwise approach again. It doesn't look completely normal, does it? But let's take a look step by step. So the rate, we've got 1, 2, 3, 4. Slightly different appearance of the complex, but include it 5, 6, 7, 8, 9, 10. So it's about 60. Rhythm. Does it look regular? I'd certainly say so. There's about 4 and a bit. And again, you could map that out if you weren't sure, but that's regular. These are also the same and regular, but then this beat here comes in, which has got a shorter R interval, and then this one's longer. So let's park these two, but take the rest of them, and it is regular. Is the QRS narrow or broad? Just about. It's an incomplete right bundle morphology, if you remember. The bunny ears of RSR and the deep S wave in V6. And it's just approaching 4 small squares. So it's slightly broadened there, whereas here it's normal. So they have got right bundle branch block. What we're seeing with these 2 beats is these are ventricular ectopics. That's why the morphology is different and they're broad. And they're ventricular ectopics coming from the left ventricle. This is sinus rhythm with ventricular ectopics, and you often get a compensatory pause. If you take out the abnormal beats, look at the rest of the ECG, there's nothing to worry about. So no is the answer, you would not refer to the pacing. So we're going to move on to tachyarrhythmias now. People often find these slightly tricky than bradyarrhythmias for some reason, but remember the same simple approach, the 5 questions of which the most important for tachyarrhythmias is it regular or irregular? If it's irregular, it's always AF. If it's regular, then the next question is narrow or broad. If it's narrow complex tachycardia, lots of people lump this together as a supraventricular tachycardia. But hopefully today, by the end of the day, we'll be able to differentiate a little more as to whether this is an atrial flutter, AV nodal reentrant tachycardia, which is the commonest, accounting for about 80%, an AV reentrant, Wolff-Parkinson-White being the classical, or a sinus tachycardia, which you may well see quite commonly if we're looking after unwell COVID-19 patients coming in with more advanced disease. If it's a broad complex tachycardia, the 3 differentials are VT, which is going to be almost always, an SVT with a bundle branch block, whether that's a right or a left, or an SVT with an accessory pathway that conducts slowly. Example, Wolff-Parkinson-White again. So we're going to look at each of these now in turn. Just to show you the ALS algorithms of tachyarrhythmias, the adverse features are again the same. If any of these adverse features are present, you proceed to a synchronized BC shock. In your own trust, so when you do your first shift, I would ask for someone to familiarize yourself with the defibrillator in your trust so that you know how it works and whether or not the energies ramp up automatically or whether or not you need to manually adjust. And if you do need to manually adjust, 150, 200, 360 joules would be a reasonable approach to use. So lots of people get very het up about broad complex tachycardias and whether there's concordance in the chest leads and dominant R waves and R primes. I think let's just simplify it. You don't need to worry about any of that. 80% of all broad complex tachycardias are VT. If there's a history of ischemic heart disease, over 95% are. And if you can see P waves in the broad complex tachycardia, it's always VT. So let's take a look at some ECGs. So let's take our stepwise approach again. So I think we'll all agree this is fast. And to save you all watching me count these in times by 6, let's just agree that this is about 1.5 in terms of the difference between the RR interval. So our rates are at 150 to 180. Is it regular? It is. Is the QRS narrow or broad? Here, the QRS starting here to here is still less than 3 small squares, so this is narrow. So now we know this is a supraventricular tachycardia. Can we tell any more? In P waves? Not particularly clearly. If you are going to look for P waves, the best places to look for them are often in V2, they often get buried, and in lead 2. It's sometimes hard to tell a P wave from a T wave. If you do see P waves, it's usually an indication of it being an AVNRT or AVRT. But if you're not sure, and in the vast majority of cases you're not, then you can use adenosine. And we'll talk a bit more about adenosine in a moment. Let's come on to another ECG. This is a 55-year-old man who came in with chest pain and low blood pressure. What's the diagnosis here? So let's take our same approach. The rate, about 150 with 2 small squares between the R intervals. Is it regular or irregular? It's regular. Again, map out if you're not clear. It takes practice to get an eye in on these. Is the QRS narrow or broad? This QRS is now more than 3 small squares. So we've got a broad complex tachycardia. Almost always going to be VT. Is there anything we can see? Someone's helpfully circled one. There's a P wave there. You know, therefore, the answer is VT. Let's have a look at another example. Much more obvious broad complex tachycardia this time, where the QRS is less borderline. It's regular, it's fast, it's broad, and again, just buried up in one, there's a couple of P waves. The other features which I did touch on, but I don't need to get hung up upon, are concordance in the chest leads, i.e. they all look the same, particularly in 4, 5, and 6, 2, 3, and AVF, and if the axis indicator, i.e. AVL being up or down, agrees with the remainder of the leads. These are all additional supporting features of VT. Let's look at another one. So, rate here is a little bit slower than the last, just over 2 small squares between them. It is again regular. The QRS is again broad. So it's a broad complex tachycardia. Looking V1, looking V2, V1 again, possibly some P waves buried. So this is again VT. This is a slightly slower rate. That may be because they're already on a pre-existing beta blocker. It may be because the heart is scarred and not able to mount a higher heart rate, particularly if it's an older patient. The other features that support it are the concordance in these leads. Apologies. And also in the inferior leads. Remember, if you see these ECGs and you're not sure, treat it as VT. You're not going to go wrong treating it as VT. Because if you're well, the ALS algorithm says to use amiodarone, which, as you'll see in a moment, is safe in almost everyone. And if they're unwell, then the default position is to put the pads on and do a DC shock. So it's a specific type of VT I wanted to talk a little bit more about, and that's called torsade de pointe, or twisting on a point, and also known as polymorphic VT. This is almost always due to a long QT, and when that happens, you get an R on the T, and it triggers this varying amplitude broad complex tachycardia, and hence the twisting on a point. This is treated slightly differently to traditional VT. If they're unstable, they have a DC shock, which is exactly the same. If they're stable, IV magnesium, asthma dosing, which is 2 grams or 8 millimoles in 100 mils of normal saline over 20 to 30 minutes. It's highly successful at curing it. And if their blood pressure is reasonable, i.e. 110 systolic or above, you can also give them some IV metoprolol, 5 or 10 milligrams, which also helps to terminate the rhythm. It's really important in these particular cases to look at their drug history, because usually there's something that's prolonged the QT. And so look for clarithromycin, tricyclics, HIV drugs, antifungals. Often the drugs we give them to try and stop arrhythmias like verapamil, digoxin, amiodarone, they're all causative. And that's the real point to stress here, is this is the only real exception where amiodarone isn't a fantastic drug, because it actually prolongs the QT. This is the only variation where we use magnesium metoprolol rather than saying amiodarone is the one shot fits all. So let's come on to talk about the rhythm disturbance you're going to see most commonly when you come back onto the acute take. And that is this rhythm. So let's take our approach. It's fast. It's going to be roughly about 150 to 160. I've removed the large small squares from this one, the large squares. So save me counting this in timesing it by 6. Take my word for it. Is the rhythm regular or irregular? Hope you can all see that the R to R interval varies. Therefore, we already know the diagnosis. It's atrial fibrillation. And just to confirm that, we can look and see that there are no clear P waves with every QRS. AF, people often call it fast and slow AF. AF is always faster than the atria. It's just whether or not your AV node is conducting that down into ventricles fast. So if you really want to sound like you know what you're talking about, say AF with a fast ventricular response rather than fast AF, or AF with a slow ventricular response, or AF with an appropriately rate-controlled response if they're on medication. Here's another example where you can see, once again, the R interval varying. Sometimes you will see P waves. You'll see that they're not in a clear one-to-one association. So don't worry if you do see P waves. The key thing is, if it's irregular like this, shown by mapping out with your paper over the RR and the rhythm strip, it's AF. How do we manage AF? Rate or rhythm control? Rate control, BCD. Tip, use one drug at a time. If you're not getting on top of it with the one drug, it may be you need to add in another drug. Don't give more than one drug at the same time. That's when you tend to run into trouble. Beta blocker is almost always the first line, and IV metoprolol is incredibly safe unless the patient is on a terbutaline infusion with unstable asthma, is not contraindicated in asthma or COPD. So IV metoprolol, adjust the dose according to the patient in front of you. If you've got someone with a blood pressure in the 120s or above, who's in their 50s, 60s, or 70s with a good BMI, you're happy going in with 20 milligrams IV straight off. If you've got a slightly more frail 50 kilogram, 93-year-old lady, perhaps you want to go in with 5 milligrams and assess the response. It wears off very quickly. Time of onset is within 30 seconds and it wears off within about 20 minutes. So do remember, if you get an exit response, not to walk away without giving something longer acting orally or with topping up. The other alternative, IV, is verapamil as a calcium channel antagonist. And that, again, is fairly good. Should not be used if you've got a concern about Wolff-Parkinson-White, and we're going to talk about that later on, or if they've got significant ischemic heart disease, because it can be proarrhythmic and precipitate BF. Oral diltiazem is very, very poor. People do use it, but it doesn't work particularly well. So if you aren't winning with the beta blocker alone, we tend to add in digoxin. You can give it IV or oral. The pharmacokinetics are very similar. It does work slightly faster IV, but the main thing is if you've got a fairly unwell patient that's not feeling great because they've got AF ticking along at a fast rate anyway, plus or minus some rate-related heart failure, the stomach may be congested, you give them 4 125 microgram tablets of digoxin, they tend to just vomit it back up. So I tend to give the first dose IV, 500 mics, 100 mils, normal saline over half an hour. And remember, the loading dose, if you're going to load someone properly, is to give 1.5 grams in the first 24 hours. The most common reason people don't get on top of AF is they don't load properly with digoxin. Or they give them metoprolol, it wears off, they walk away. When to choose rhythm control over rate control, and this is the same for fibrillation or atrial flutter. So if you have an unstable patient, as per the algorithms we looked at earlier, i.e. they've got ongoing chest pain, they're shot, i.e. shut down peripherally or centrally, with a low blood pressure, low urine output, they're in crushing heart failure, or they're having recurrent blackouts in front of you. The only other time we do it is if we have a very clear onset of the symptoms and the patient's a fantastic historian you can rely on, or you've got an ECG from 48 hours ago showing they're in sinus and now they're in AF. Because beyond that, there's been enough time for a clot to form in the left atrium and there's a risk of stroke. So you wouldn't do it without a TOE guiding it beyond the 48-hour period. So let's look at another ECG. Let's not be scared. It looks a bit different to the other AS we saw. Let's just use the step approach. Is it slow or fast? It's fast. Is it regular or irregular? It's irregular. We map out. Here we can see they're quite close together. Here a much longer period, almost double. Here, longer, longer. So we've got an irregular fast rhythm. We know it's AF. What else is going on? It's AF with left bundle. William and Marrow, if you remember from medical school. William up in V1 and V2, and Marrow, if we zoomed in on V6, we'd see it better. So it's quite common, particularly in the elderly, to get some rate-related conduction changes, i.e. the faster you go, a bit like everything in the body, the conduction system gets a bit tired and you may develop left bundle at a certain rate. So it's useful to slow them down and see if the left bundle's gone, because then you can be reassured that this isn't a new left bundle, i.e. an acute STEMI that needs to go to the cath lab. It's also useful to look at their old ECGs, so they may have had it already. Don't forget, in patients with AF flutter, to counsel them about the risk of stroke. There are some very helpful free apps now on your phone. There's the ClinCalc app or the MD Calc, both of which give you access to these two scoring systems. This one, the CHADS2 VASC, for calculating their risk of stroke, and the HASBLED, their risk of bleeding. And you just put in the patient's characteristics, having got a history of heart failure, high blood pressure, what's their age, 65 to 74, 1 point, 75 and above, 2 points, diabetes, are they a lady? You get a point for being a lady, I'm afraid. Have you had a stroke before? Have you had another vascular event, a peripheral vascular embolic event, or an MI, a TIA, or stroke would come into here. And then HASBLED, similarly, made up of these components, and you'll come out with a score. All men with the CHADS VASC score more than 1 without having a HASBLED score that's outrageous should be anticoagulating, and all women with a score more than 2, given that they get 1 just for being female. We tend to use NOAC's first line, and again, I'd familiarise myself on starting back in A&E what they tend to use. In Oxford, we use apixaban because it was given the best balance of bleeding and efficacy, but some other trusts opted for other ones because they've got a once daily regimen, for example. So next, we're going to talk a little bit about antiarrhythmics. So another nice, simple mnemonic. I know doctors like mnemonics. Be safe. And the same tip is stick to one drug. So B, beta blockers. These are your best friend. As I said, ivabitoprolol, used in almost everyone. And it's fantastic. It works rapidly and it's got a rapid offset. It's got antiarrhythmic properties as well as being a rate controlling agent. So you may well convert, for example, back into sinus rhythm. Sotalol, think of it as your special beta blocker. So it's a beta blocker with extra antiarrhythmic capacity. It's a class 3 agent on that very funny thing you might remember from med school called the Vaughan-Williams classification. So it's a bit like amiodarone, and it has that extra ability to cardiovert people back or keep them in sinus rhythm. The caveat to using sotalol is it lengthens your QT. So if you've got someone whose QT is long, and when I say long, the limits you would start it at would be no more than 470 milliseconds for a woman and 450 for a man. If the QT is above those, I wouldn't start sotalol. If it's below those, then you start it and you just make sure that we monitor to arrange for that follow-up to happen. Amiodarone, as I said, is fantastic in almost everyone. It works in almost all situations. The caveat being Torsade, because of the QT lengthening, it's the drug you wouldn't want to use there. Flecainide, think about only if fit. So it's very good if you've got a young patient in front of you with new AF or flutter. Cardioverts them very, very well. tend to give 100 milligrams and again and 100 mils of saline over half an hour. You do not use it in people with adult congenital heart disease, structural heart disease, or ischemic heart disease because it can precipitate VF. Hence the only fit and electricity suitable in everyone, including pregnancy, and it's completely safe in pregnancy as well. Let's have a look at a couple more ECGs. So let's take our stepwise approach. Is it slow or fast? It's fast. It's going at about 150 or 160. Is it regular or irregular? It's regular. Is the QRS narrow or broad? It's narrow. So I've told you the answer there because there are these flutter waves down here. You may not spot this. And in fact, in this particular instance, the doctors who were seeing the patient didn't. So completely reasonable if you've got a narrow complex tachycardia like this to give adenosine. And adenosine given to this same patient shows you this beautiful sawtooth pattern of the flutter waves.
Jamie, can I just pause you for a second? Everyone take your headphones off and see if you can hear some clapping in the street. I certainly can. People are clapping right now for the NHS and for social care. I'm going to clap my colleagues too. But just a brief pause. I'm sorry. You can go back to your ECG now. Thank you.
Okay, thanks for that, Lizy. So this is the same patient after 12 milligrams of adenosine. Always put the pads on before you give the adenosine, and allows you to print the rhythm strip from the defib at the time so that you can show people down the line exactly what's going on with the rhythm. For example, if you wanted to refer them to a cardiologist for a flutter ablation. Remember to warn the patient that they're not going to feel well for about 20 odd seconds, and the half-life is 12 seconds. It takes 24 seconds to wear off completely, 24 to 30, and it makes them feel exceedingly unwell because it's stopping all communication between your atria and your ventricles. So you really do feel like you're dying for those periods of time. But I don't tend to say that. I say, it'll make you feel unwell, breathless, and tight-chested, but it'll soon pass. Let's look at some more ECGs. So we've got a 72-year-old man who's come in breathless. It's fast, it's regular, it's narrow complex. Can we see any P waves? Not convinced, but it does look a little bit sawtoothy again. So we're pretty sure this is going to be flutter. With flutter, it's really nice. It behaves in a very fixed pattern. So it's the AV node controlling the rate at which that flutter circuit can go down into the ventricles. So it's either going to conduct every second beat, in which case you'll get a rate like this, around 150, every third, in which case the rate would be 100, every fourth, in which case the rate would be 75, or every fifth, in which case the rate would be 60. So here we've got flutter with 2 to 1 block. The thing to say about flutter, it's a lot harder to rate control than AF. You can't offer them cardioversion if they're well, unless you've got a clear onset of less than 48 hours, in which case you can offer chemical cardioversion with flecainidation and FIT or amiodarone if unsure about their structural status of their heart, or if they're old enough to potentially have significant coronary disease. Or you can offer them electrical cardioversion if you're in a cardiac center which is willing to do sedation and do that. But in the vast majority of cases, it's hard to sort of justify. And if you're not feeling comfortable, so you need to try and rate control it. And often this is the case where you need to use the combination of beta blocker and properly loading digoxin to actually get on top. And then we don't like leaving people in flutter for a long period of time. People tend to get a tachyarrhythmia induced LV dysfunction or tachycardiomyopathy. So we do tend to try and cardiovert these as soon as they've been on the NOAC for long enough, i.e. 3 to 4 weeks. Let's look at another ECG. Hoping you're seeing a pattern, the lovely sawtooth pattern in the rhythm strip. This is flutter again, but your AV node is conducting it more slowly. And this is perhaps someone that's on a drug to slow their AV node down, or their AV node's just not conducting as well. And this is someone that may need pacing in future. So we've got 7 to 1 block in this particular instance, with roughly 7 large squares between these hour intervals. A slightly more tricky one, a 93-year-old man who's on a tenolol, enalapril, and furosemide. He's coming feeling exceedingly lightheaded, he almost blacked out today. So if we take our approach again, we know this is a slightly fast heart rhythm, and the speed on the rhythm strip times it by 6, or the hour interval, we're just about 90 beats per minute. It's looking regular, and we can map out again if unsure. The QRS is narrow. And next thing is, are there P waves? And this is where it gets a little more tricky. So there's certainly P waves here and here, and there also appears to be another P wave before the T. So is this 2-to-1 block? It's going very fast if so. Mobit's type 2 with 2-to-1, or is it flutter? Because you do think again, and this is a little bit irregular. What are we going to do? We're going to give adenosine. Give adenosine, we basically show this is flutter. 20 seconds later, it's worn off, and he's back in atrial flutter, and we need to do something more about his rate. So let's talk about adenosine. It has no long-lasting effect. Do not be scared. It's underdosed in ED because people are scared of it, and it's the commonest reason we're called, when people can't get on top of a narrow complex tachycardia. ALS, state 6, 12, 12. In reality, 6, 12, 18, 24 is what we do. I'd understand if you're going up to 18 and you're getting no response, it'd be quite reasonable to call for help at that point. What does it do? But if the circuit's involving the AV node, it will terminate it. There are very, very rare instances where if you've got a very slick AV node, it's a very fast circuit within that AV node, that by the time the adenosine is worn off after 25 to 30 seconds, the circuit can restart. Those are the cases where you see it stopping on the ECG and then restarting, and we go to higher and higher doses. And what we do there is give an additional agent that slows down the AV node, so either metoprolol or either niraparib. You give that, and then you give the adenosine and you stop it permanently. That's very rare. You won't come across it commonly. If it's not an AV nodal circuit, however, it's not going to terminate it. All it will do is transiently slow it. As we've just seen, it will do that, and then your flutter will be back up. So it will do that if it's AF, if it's an atrial tachy, if it's flutter. A little bit of other really useful information I think people don't get taught enough regarding ECGs, and it's regarding pace ECGs and those with defibrillators. So for a patient coming in with a standard pacemaker, and usually you hope patients carry their card with them, so it tells you what type of pacemaker. But otherwise, look at an X-ray. On the X-ray, you've got the pacing leads with no coils, and this is a dual chamber, an atrial lead and a ventricular lead. Here's the box. This is a standard dual chamber pacemaker. If you put a magnet over the box, and there are magnets in almost all defibs and all EDs, the little blue round ones normally look like a donut, and you have to leave it over the box. And what it does is it flicks a reed switch within the pacemaker, and it reprograms it to the manufacturer's baseline rate. And it's still like a BMW, a Volkswagen, a Ford. They've all got their own preset rate. Like every car has a resting rate per minute that differs. But basically, they're all between about 90 and 104. So you'll tell the patient you're going to feel your heart rate speed up, and you will see the pacing spikes up here, and the heart rate will track up to 90 to 100. And then when you take the magnet off, the pacemaker returns to its normal pre-programmed function. So in this particular crisis, where we've got no cardiac physiologists or very few working a skeletal service because of COVID-19, you've got people coming in with falls with a pacemaker. This is how you can confirm the pacemaker is working. If you have an ICD, what that magnet does is it deactivates therapies, i.e. shocks. You would only want to do that in the case of a VT storm where you don't think the device is helping you. And usually you'd want a cardiologist there at that point anyway. Or the other indication would be emergency surgery because of a car crash. You can't hold a physiologist, so you leave the magnet on for the period of surgery. It can still pace. It's not going to defibrillate them accidentally while the surgeon's delivering diathermy. Just a reminder, that's a standard pacemaker on a chest X-ray, and this is what a defibrillator looks like with the coils. These are the defibrillation coils. I can't do an ECG talk, sadly, without talking about acute coronary syndromes. So I will talk about STEMIs and NSTEMIs very briefly. So I'm hoping everyone can spot this particular ECG. This is one you don't want to miss. And this is an anterior STEMI. And lots of people get confused with what's ST elevation, what's high takeoff. If you're ever uncertain, then usually with the STEMI, you're going to see something called reciprocal change. So where you've got the ST elevation here, you look for reciprocal change in the other territories of the heart. So if it's in the anteroseptal, you look in the inferior territory. And down here, you'll see reciprocal change. What I mean by that is if you flip the ECG over, we'll look at STEMI in the inferior leads. We look at this one, you can see, and when you're looking at ECGs for ischemia with people with chest pain, look at them in clusters, 2, 3, and AF being the inferior, V1, V2 being the septum, V3, V5, or V6 even as the lateral, and then 1 and AVL together as the high lateral. So here we can see ST elevation, definitely more than 2 millimeters, even without the squares. So it's fulfilling the criteria for your primary PCI pathway. And yes, nice, we have reciprocal change in the high lateral leads of 1 and AVL. It's also first degree heart block. This is another ECG that I want you to all be familiar with, and I'll share these slides at the end so you can have them as a reference. And this is the most important NSTEMI. So it's important at the moment with COVID-19, lots of trusts are managing NSTEMIs medically. So in Oxford, as of Monday, we are going to manage our NSTEMIs medically and bring them back for an outpatient angiogram unless they've got high-risk features such as ongoing chest pain, dynamic changes, etc. And other trusts are, again, you know, just sitting them on a medical ward rather than a cardiology ward, so they're cohorted until they've had their period and fully recovered. They're no longer infectious before they get to the cath lab. There are some cases where this isn't going to be safe, and this is a particular ECG where it's not. So here, V1 and V2, notice the T wave up and down, a biphasic T wave. Although you've not got ST elevation, this T wave is not normal. It does not like the T wave in V6. This is something called Whelan's syndrome. There's a nice article on Wikipedia if you want to read about it. And essentially, it's acute LAD infarction caused by a plaque rupture, usually in the proximal LAD, and it should be treated as a STEMI because you're going to lose almost all of your heart muscle. If left untreated for 20 minutes, this is what the next ECG will look like. And the key thing is, if you see an ECG like this, repeat it and keep the patient in. And the ECG, when it goes like this, they really need to be going to the cath lab. The T waves are deepening and spreading from the V1, V2 throughout the rest of the territories. This is a patient who was in Oxford day 1 post-bypass surgery. We're not infallible. It's time of cardiac surgery, but cardiac surgeons aren't infallible despite what they believe. And this patient developed some chest pain. It's always hard, but their ECG after the bypass was relatively normal. And here, this is the commonest missed STEMI, and it's a posterior STEMI. And it's really important to always look at lead 1. Lead 1, remember you only need 1 millimeters in the limb leads, not 2 millimeters like you do in the chest leads. And here you've got a good millimeter and at least 2 millimeters in 1 and 2. And again, a reciprocal change in AVL. And you've also got the estimation extending slightly further around to 5 and 6. So it's time for a quiz now, which I'm going to try and do with Lizy and Kirsty. So I don't know how, I'll just give it a whirl, but basically I want people to come in on the chat with their answers, if possible.
Yeah, so if you've got an answer, you can raise your hand and I will unmute you so you can share it with the class.
Excellent. I don't know who anyone is, so don't worry. This is a completely safe place. Don't worry if I get it wrong. We're here to learn. Okay. If I don't hear anyone speaking after 30 seconds, for my own sanity, I will answer the question myself. Okay, off we go. Remember the stepwise approach. Is it fast or slow, regular or irregular, broad or narrow? Are there P waves? And are these P waves associated to the QRS? Does anyone have their hand up?
Yeah, hang on, I've got one. Let me just, Rebecca Shakir.
Hi, Bex. Sorry, anonymous. I do know Rebecca very well, so she'll definitely know this. We work together.
Is it VT? She said, is that VT?
It is. Well done. So just to take everyone through it again, it's fast, it's regular, it's broad. So as we said earlier, 95% of the time, we're going to treat this as a VT. And here, someone's helpfully drawn the lovely P waves for you, so you know if you see P waves that it's definitely VT rather than any of the weird and wonderful rare variants. Well done, Bex. Let's look at another ECG, and this is why it's really important not to just read the top part of the screen. So the clue here is that this is not right. Does anyone want to come in with an answer?
Dana Maria Rogajan, tell us the answer.
VT?
Well done, well done, well done. So yes, don't trust what's written there all the time. So this next one is slightly trickier. This isn't a standard ECG you'd be familiar with, so I won't test you on this particular one. I'll just walk through it. So this is what it looks like when you interrogate a defibrillator. The top leads here being the 3 rhythm strips that they, and then the rhythm strip at the bottom. And what you're seeing here is, again, a broad complex tachycardia. Here is delivery of a shock, and then the device in place. So that's the defibrillator working properly for someone getting an arrhythmia. Okay, back to the quiz.
So Gabriel Funingana? Gabriel? No?
Yeah.
Kalyan Schechter? No?
Okay, no.
Yep, first degree heart block.
Excellent, well done. Very, very good. So we can agree it's all regular, rate somewhere around 80, and the QRS is narrow. So the next thing to do with the fourth question, are there P waves? Yes, there are P waves at every QRS, but as you long distance between those P's and the QRS, so this is first degree heart block. Well done. All right, next.
Rashpal Gatura. Go ahead.
2-to-1 block.
So I could see why you might think that. So you're not far off. So it's certainly a high degree AV block, and that's always a good get out clause if you're ever speaking to someone. You're not sure if it's second or third. So let's go through it. So it's fairly slow. We've got 1, 2, 3, 4, 5, 6, 7 R waves along that bottom rhythm. So a rate of 42. It's regular if we map them out. And the QRS is narrow. So the next question, are there P waves? Yes. So if you're not sure, and then map the P waves out like you do the RR. So here you will see the RRs are fixed because we've got a nice protective heart rhythm, but the P waves are not. If it was 2-to-1, this would maintain fixed. So it would be 2 for every QRS, or 3 for every QRS, or even 4. That's mobile type 2. Here, the P waves mapping out do not match up. There's complete AV dissociation. This is complete heart block. This is an ECG people get really het up about all the time. So I'll talk you through this one rather than testing. Essentially what you're seeing here is a regular beat followed by a broader morphology. Beat along here. If we just focus on the regular ones, they are regular when you map them out. There is a P wave with every QRS, so it's sinus, but you're having a ventricular ectopic with every sinus beat. So this is called Ventricular by Germany. It makes people feel really unwell, and essentially it halves your cardiac output. And generally it's related to significant disturbance of your calcium, magnesium, or potassium levels. So it's important to just check those and correct them if you do see an ECG like this. This is another ECG where it's one of those you just need to recognize. I guess the next few ECGs I'm showing you are the ones you're not, I don't want you to miss if you're coming back to practice. And if you see it, the red panic button hits. Does anyone know what this ECG is? I'm conscious of time, so I think there's 3 more to go. And then I just want to have some time for the questions I've got. given fibroid approach. It's slightly fast. It's regular. QRS is starting to broaden, and it's not quite at the broad complex tachycardia. I appreciate I haven't given you the background strips for you to actually count whether it's more than 120 milliseconds. It certainly appears to be broadening. And then the question of P waves. So we know that if we see P waves scattered throughout, it's VT. But if we see P waves fairly regularly, what is it? This ECG is hyperkalemia. So it's small or absent P waves. They're often very hard to see. The QRS is broadened and the POs are tented. You see this ECG, someone that's coming in a mild venous gas. And generally a venous gas on everyone coming in with palpitations, chest pain, or any cardiac presentation is going to be extremely useful. Next case. This one I do want someone else to answer. I've helpfully put some arrows on there for you as well. So it's a 40-year-old man, palpitations, almost blacked out, and his blood pressure is exceedingly low. So the first question for someone to answer is, what is the diagnosis? Anyone having their hands up? No? No volunteers? Okay.
I'm sorry. Yes, there is, but I'm having a problem. So go ahead. I'm so sorry for you clever people who I can't see.
If you do know it, you get a gold star. So let's talk through it. It's fast. The interval between here, we're approaching almost 200 beats per minute. It's regular or irregular. Well, it's very hard when they're going very fast to try and look on the ECG where the always look the most normal. And if you look here, it's going one small square exactly, whereas here it's more than that. And again, here it's even less, and here it's more. So it's actually irregular. So we know that anything irregular is AF. So we just need to figure out what else is going on. Is this AF with bundle branch block? Or is it that really rarity AF with pre-excitation because of an accessory pathway, and it's going down the accessory pathway rather than the AV node? And the clue is on the 9th beat. 1, 2, 3, 4, 5, 6, 7, 8, 9. And just here you see a normal beat snuck in amongst all of those. And this is the fabled delta wave. Here it's irregular. So this is AF with pre-excitation. And just to illustrate what that is, if you remember in our first slide, we looked at the SA node, so the AV node, the Purkinje middles of his. This is an accessory pathway, and it can go either way. And if the pathway conducts slowly, that's great. If the pathway conducts fast in AF, you've got an ECG looking like the one we just looked at. This is another ECG of the same thing. So you've again got this broad complex tachycardia, but it's irregular, probably more obvious than the last case. And again, the question then is this just AF with a bundle branch block, or is there evidence of pre-excitation? Look carefully for those normal beats. Where those normal beats are, again, you see the delta wave. This is another ECG not to miss.
Okay, hands up.
And give you a clue, the patient's had a fever.
Oh, Uchenna Ozo? Go ahead. Sorry?
You got it.
Excellent. So here is the key finding on this ECG. You have an RSR pattern. It doesn't look like a normal right bundle. You get this sloping S wave. And the J point we talked about earlier is way higher than normal. And that's the key. This ECG is pathognomonic. You don't do any further tests if you see this ECG. The key thing is you take a family history, if they've got a family history of syncopatic death, but if they've already presented with syncope, you don't send that patient home. The next patient, day 5 post-hemicolectomy. Any volunteers coming forward?
No, sorry, no one knows.
This is the classic one you get taught in med school of sinus tachy with right bundle with S1, T3. If you see this, it's almost always a PE. This is an 18-year-old girl who's a twin. She's blacked out at a pop concert. First question is, what is the diagnosis?
No.
So this is long QT, and when you're measuring the QT, you start the Q and you go right to the end of that T wave return to normal. The normal length, as we said, for a woman is about 470, 450 for a man. We can see here that we've got almost 200, 400, we're approaching 600. You do correct it for the speed, and again, MedCalc or ClinCalc for you, or you can do it online using Baze's formula just on Google. So here we're looking well into the high 500s corrected. This is long QT, often triggered by a loud noise. The other testing that should be done is screening, genetic screening. I realized on an earlier ECG, I didn't answer the very key question. And obviously when we anaesthetist, hopefully in ED, but they may be at the moment. Which antiarrhythmic would you give? Well, the patient's shocked. It's a trick question. You would shock them. And I think the last ECG coming up is this ECG. So it's a 16-year-old boy who's collapsed playing rugby. Does anyone know the spot diagnosis on this one? And this is again a pathognomonic ECG that I just wanted to show so that you've all seen it.
Uchenna Ozo?
Hypertrophic cardiomyopathy.
Excellent, well done. And the test to confirm it would be an echo plus or minus an MRI and then refer that appropriately. Well done. So the summary, because I'm running over, we've covered the basics of conduction, looked at Brady and pacing indications, we've looked at Tachy, the approach to BT, the B-safe antiarrhythmics, and the ECGs not to miss, the long QTs, the HOPEMs, the pre-excited AF, and the Brugados. Thank you very much for watching. How many questions have I got time for, Kirsty, if any?
I think that you have no time for questions, I'm afraid, because I'm conscious that I really do want everyone to have the chance to have a little bit of a comfort break before we start the AKI in 2 minutes.
Do you want me to write responses to the questions for you to circulate?
Do you know, that would be fabulous, and we'll circulate that with the recording. So thank you so much. We'll take a tiny comfort break and we'll come back.
Give me a second.
So that will be recorded, this will be recorded, and both sessions will be available afterwards. Do just give us a few days to edit them thoroughly and we'll get them on the HE website.
There we are. So I would hope, you can now see my slides, is that right?
We can, that's correct.
Lovely, so thanks very much. So yeah, my name is Matt Bottomley, I'm a registrar and a clinical lecturer of renal medicine here in Oxford. I've put my Twitter handle there for anyone because obviously this is going to be reasonably fast moving and there's over 500 of you, so there may be questions we don't have time for or questions you think of in the next day or two, and feel free to tweet me and ask and I'll do the best I can to answer, and obviously no patient specific things. Right, so let's talk about AKI. Firstly, we're going to talk about why it's important, and we're going to talk about why people get it, what are the risk factors for it. I hope you'll walk away with a sense of what's the initial investigations and management of an AKI, and we'll talk briefly about the use of IV fluids. And also we'll talk about situations that specifically require you to call a nephrologist. And just because it's the topic of the moment, I've put a slide in about AKI and coronavirus, because obviously that's something that everyone's very mindful of. So what is AKI? Now, the simplest thing is it's a sudden and recent reduction in a person's kidney function. It's a very simple definition, and for many years that was all we had, which meant that studies used their own definitions, and it was all very confusing. We know it's frequent. 20% of admissions in the US will have an AKI. And we know that it costs the NHS an awful lot. It costs somewhere in the region of £500 million a year to the NHS. And actually that's more than breast cancer and lung and skin cancer combined. So it's a serious amount of money that goes into treating and dealing with AKI. And about 10 years ago, just over 10 years ago, there was a very famous report in the renal world, which was called Adding Insult to Injury. And it looked at how we're managing AKIs in the NHS, and we were doing it really badly. We had up to 100,000 inpatient deaths a year associated with an AKI, of which 15% were avoidable. So if you just simply do the maths there, that's 15,000 deaths a year that were potentially avoidable. And as a consequence of that, it was recommended that all acute NHS trusts have an AKI guideline. The NICE have published guidelines in 2013, and it's considered that a predictable and avoidable AKI should be a never event, but actually very few trusts take that policy. What I would say though is wherever you're working, it is worth going and having a read through their AKI guideline. It's usually written by a nephrologist, but it's written for medics, for surgeons, for psychiatrists, for gynecologists. So it's written in very easy to understand language and is usually just a checklist of things to do so that you don't miss something silly. So what causes AKI? Well, there was a big study done about 15 years ago, which looked at 54 ICUs in the developed world, and they looked at best part of 2,000 patients with AKI or needing renal replacement therapy, so you presume a severe AKI. And what they found was actually the vast majority of contributory factors were pre-renal in these patients. Now, there is overlap here. Patients can have more than one cause, but what you can see, the ones I've highlighted in blue are all pre-renal. The one in red, obstructive uropathy, only about 3%, and glomerulonephritis, which is the thing that everyone thinks about and gets excited about, actually was relatively rare, about 10%. And so what that really does, it frames the talk we're going to do tonight. We're going to talk predominantly about pre-renal. We're going to talk a little bit about obstruction, and actually I'm not going to talk at all about glomerulonephritis except for how to recognize it, because really those are the things that you need to be calling us about, and you can go do a little bit more reading in your own time about glomerulonephritis if you really want to. It's about recognizing it, really. So, who's at risk of AKI? Well, there should be no real surprises in this list here. You should have a low index of suspicion for an acute kidney injury if a patient has an acute illness of whatever cause, and they're over 65. They've already got renal impairment. They've got some other organ dysfunction. They've had AKI in the past. That's usually because there's a contributory factor that's still there. They've got oliguria, and either that's because someone's dutifully recorded it on the fluid balance, or it's the patient says, I haven't peed since yesterday. They provide symptoms or a history of obstruction. So they say, I've been struggling to wee for the last few days. It's just a little dribble. It's really struggling to come out. They may talk about having to get up multiple times at night, all those things. Sepsis is associated with AKI very strongly. If they've got signs of hypovolemia, and we'll talk about that shortly, and if there's nephrotoxic drugs or radiological contrast involved in the history. So that might be they've had a CT scan recently, or it might be that they come in and they're taking drugs which you know are associated with an acute kidney injury. And I'm not going to talk too much specifically about nephrotoxic drugs and what those are, because there's a long, long list of them, and whatever I tell you, I'll miss an important one. So I will mention them in passing, but I'm not going to talk about them specifically. So how do we go about measuring AKI? Well, the thing that we'll all be familiar with is the EGFR. It's now reported automatically on computers. So whenever you request a renal function, you'll get an EGFR. Now, the problem is that the EGFR equations were only validated in chronic kidney disease stable patients. They weren't validated in the setting of an acute kidney injury. So that we don't tend to use them in the nephrology world. And actually, we tend to use the creatinine as it is, and it's a much better reflection of short-term changes in kidney function. And so if you speak to a nephrologist in an acute kidney injury and talk about EGFR, actually they'll just ask you to talk about creatinine. The problem is it's not a perfect marker. There is a lag effect. If I chop out both your kidneys today, then your creatinine tomorrow, assuming it was normal today, will probably be 150. The day after will be 250. And if I run that through an EGFR equation, that would tell me that your EGFR when your creatinine is 250 is somewhere around about 20. But actually your true GFR is 0 because you have no kidneys. It's just the lag effect. And the other problem is that actually it's a relatively insensitive marker. Now this is a graph of GFR versus creatinine. Now what I want to just show you is that if we take the normal person with a GFR of say 60 and it drops to 40 for some reason, what you see is actually their creatinine changes relatively little. And it's only as it drops below 30, you start to see marked changes in creatinine. And it means that people miss subtle changes because you don't see the change in creatinine early on. So creatinine is not the be all and end all. And it means that people are looking for other markers for how we identify renal impairment in these patients early. And something you may have heard of is something called NGAL, but I'm not going to talk about that tonight. What it actually means is the best real-time marker of renal function that we have is your urine output. It's a minute-by-minute thing, an hour-by-hour thing. So if you want to track an AKI, monitor the urine output. It's better than anything else. So how do we go about assessing AKI? How do we go about stratifying it? Well, the AKI network, AKIN, came up with this a number of years ago, and we're still using it now because it works very well. Now, it goes through 3 stages: early, moderate, and severe, and that associates with worsening renal impairment. So you can use urine output, you can use relative creatinine rise, or you can use absolute creatinine rise. And all 3 are equally valid, and whichever one takes you into the furthest level is the one that you should follow. So if someone is anuric for greater than 12 hours, but their creatinine hasn't yet gone up by a 3-fold rise, that still counts as a severe AKI. And this is a slide that's just worth, you don't need to memorize all the figures, but it's just worth recognizing that there are different ways to do it. And really the one that's useful when someone comes into hospital is that middle line. What's the relative creatinine rise? Compare it to their baseline. If it's doubled, then it's an early. If it's tripled, it's a moderate. If it's greater than tripled, it's a severe. And the reason why this is important is because if you look on the right-hand side, the odds ratio of death correlates with this. If you look at someone who's got a severe AKI, they're 8 times more likely to die compared to someone who doesn't have that AKI. And that was taken across a number of diseases in an ICU. And the other reason why it's important is because if you then go on to require dialysis as a result of your AKI, across all comers, the 90-day mortality is about 50%. Now, there are very few things in medicine which has a median survival of 3 months, and most cancers don't. So it's a significant thing if you get to that stage, particularly in older people. So how do we approach AKI? How do we think about it? Well, we look at it in the way that you were probably taught in medical school. I still use this in my day-to-day because it works very nicely. We think about pre-renal. That's the blood supply to the kidneys. Has something happened there? Are you hypovolemic? Do you have diarrhea? Are you shocked from sepsis? Has something blocked the blood supply to your kidney? So, for example, have you thrown off an embolus from AF, for example? The other possibility is that you've got something else that's affected the blood vessels. So, for example, atherosclerosis, and again, some sort of plaque rupture. Intrinsic renal. So again, you can, if you really want to be funky, you can break that down into the 3 main parts of the kidney. Now, believe it or not, we are simple folks as nephrologists, and actually, there's only 3 parts of the kidney: the glomerulus, the tubulointerstitium, and the vascular compartments. And it can be any one of those things. And then finally, there's the post-renal. And that's really something downstream of the kidneys. So are they in retention? Is there a tumor that's blocked both their ureters so that actually they're not draining urine and so on? So let's talk about some cases. That's always a good way to frame things. So 64-year-old lady referred to the ambulatory unit in your hospital where you're working by her GP. She's got a pretty standard past medical history nowadays. Type 2 diabetes, she's had it for nearly 20 years, ischemic heart disease, having had an MI in 2012. She's got a bit of renal impairment and she's got hypertension. She's on a long list of medications. Now, going back to what we talked about, is this lady at risk of AKI? She's in her 60s, though admittedly less than 65. She's got a history of diabetes, she's got a history of heart disease, she's got a history of hypertension, she's got pre-existing renal disease. She's on ramipril, that's an ACE inhibitor. That reduces the blood flow to your kidneys, and that's a protective effect most of the time because it stops the glomerulus working too hard. But of course, that can become bad if you drop your glomerular perfusion pressure for some other reason. She's also on indapamide, that's a thiazide diuretic. She's on omeprazole, and that's a proton pump inhibitor. And she's also got this 3-day history of fever, diarrhea, and vomiting. So the first question is this lady at risk of AKI? And I would like to think we would all agree that she is. And what type of AKI might she have? She's probably got a pre-renal AKI if she's going to have one. So what things might we ask the patient? What else would be important to ask her? Well, we're going to ask her if she's had any contact with the people with diarrhea and vomiting. We're thinking, is this a gastroenteritis? She's been abroad recently, thinking about weird versions of gastroenteritis. Talking specifically about renal things, the use of any other medications. You'd be amazed how many people have a fever, they feel unwell, so they start popping ibuprofen. And of course, in the setting of an AKI, you add NSAIDs in as well, and you can make it much worse. You'd ask about urinary symptoms. So Are you still passing urine? When did you last pass urine? Have you noticed any change in your urine? Is it darker than normal? Is it lighter than normal? A question we always ask is, have you noticed any blood in your urine? Because if there's blood in the urine, that could be coming from the kidney. The kidney could be bleeding, and that's usually a very catastrophic glomerulonephritis. But actually, if it's coming from the bladder, then it could be an obstruction. There could be a tumor there that's now obstructing the kidneys. Again, you would also want to ask about if they know any about previous renal problems. The patient may not know, but nowadays in this IT-savvy society, we can usually look at their old renal function. And the other things we'd also ask as standard, which isn't on here, is things about, for example, are you short of breath? Are you swollen at all? Assessment of whether they've got fluid on board or whether they might be dry. What are you going to do next for this patient? You're going to examine them, of course, and you're going to do a fluid assessment, and we'll talk about that in a minute. You're going to check their blood pressure and get some observations. We would always dip their urine if we were concerned there could be an AKI. You're going to stop any drugs that could make an AKI worse. So you might hold their antihypertensives, you would stop their ACE inhibitor, and of course, if you feel they're dry, you're going to give them some IV fluids. And the reason I've chosen an ambulatory unit for this is that you won't have the blood results straight away. They've just walked in through the door, and you may be the first person to see them. So you're going to go on clinical judgment. So let's talk about how you assess fluid situations. Just a brief reminder. So there's two real states of pathological states. There's hypovolemia, when you have a deficit in overall body fluid, and there's hypervolemia when you have an excess of overall body fluid. And there's some causes there. Skin turgor in this situation. Generally, it's a poor sign, skin turgor. I'm sure we've all touch the skin of a 90-year-old, and they've all got fairly loose skin that's kind of got poor skin turgor. So actually, it's not a great marker, but in younger people, it can be. If you pinch the skin on the hand, does it immediately flap back into place, or does it remain in that tented position, slowly return to normal? Their peripheral temperature, touch their hands. Do they feel cold? Do they feel warm? The problem is, of course, if someone is profoundly fluid overloaded, they stop perfusing their peripheries because the heart is struggling. So it's not a great marker, but in someone where you don't suspect that, it can be useful. Capillary refill. Now, some people will say different things. Some people say less than 2 seconds is normal. Some people say less than 3 seconds is normal. It's really just the same marker. It's the same test, really, as the peripheral temperature of the hands. Check the capillary refill, and if it's prolonged, that might suggest hypovolemia. I find the JVP one of the most useful things. And the problem is, of course, it's very difficult to assess JVP if you're not looking at them regularly. And actually, the reason why it's useful is because it does give you an immediate sense of what's their intravascular state like. So if it's low, you lay someone to 45 degrees, you look down the line of sternocleidomastoid muscle. If you can't see it at 45 degrees, you lay them a bit lower. Can you see it now? If you still can't see it, you go a bit lower, and that gives you an indication that it's probably low. And similarly, if they're at 45 degrees and it's clearly raised, you can see it halfway up their neck, it's elevated. So it's a useful marker of intravascular pressure. Pulse and heart sounds, someone may be tachycardic if they're shocked, or if they're hypovolemic. But of course, remember that their medications may cloud the picture a little bit. They may be taking a beta blocker, for example, as this lady is, which means that she won't be able to mount a tachycardic response. If someone is fluid overloaded, again, they may be tachycardic. The heart is desperately trying to keep up with this extra fluid, and they may have extra heart sounds, and that creates this so-called gallop rhythm. Blood pressure. It may be normal if they're compensating, particularly in young people. Blood pressure is one of the last things to go if they're dehydrated. But what might really reveal it is a postural drop. Get them off the bed and repeat it. If it plummets, it means they're probably dry. Similarly, blood pressure in the setting of fluid overload, it could be anything, because they could be raised if they're fluid overloaded, it could be normal because they're compensating, or it could be low because the heart is now struggling to cope with the fluid and the cardiac output has fallen. The lungs should be clear in hypovolemia unless there's another lung pathology, whereas obviously in hypervolemia, you may hear sounds of fluids. You may hear crepitations, you may hear reduced air entry, or it may sound completely normal if they're compensating. Peripherally, they may have edema if they're fluid overloaded. Now, the problem is that this is all great in a textbook, but actually in real life, there is overlap between the two. Sometimes someone's hands feel cool, but actually they've got a bit of edema, they've had some diarrhea, their tongue looks a bit dry. So actually, it's all about the global impression, and there's no there's no single marker that gives you the answer in these people. So it's getting the overall impression, and sometimes it's very difficult because they can actually have both states at the same time. So for example, if someone has chronic heart failure, they may be edematous, then they suddenly get diarrhea. they've still got the edema, but now they're intravascular deplete. So actually you can have both states at the same time. And the one thing I would say is, if you were going to have a go at treating these patients, plump for one of them. Are they fluid overloaded? Are they not? Don't try and sit in the middle and give them fluids and diuretics, which I've seen done before. It doesn't do anything. You're just treating yourself. What you need to do is, if you think they may be dry, give them some fluid and reassess. If you think they're overloaded, give them a diuretic and reassess. And you need to pitch for one or the other. You're allowed to be wrong, because you can always go for the opposite. If you give the diuretic and they get worse, you can then give some fluid, and vice versa. So let's go back to our case. So she gets admitted to the medical unit, and she's hypotensive. She's got a normal blood pressure, but normal heart rate, but of course she's on a beta blocker. But clinically, you decide she's hypovolemic. She's got a creatinine that's over twice her baseline, and she has a potassium of 6. So you make the decision, quite rightly, to give her some IV fluids. What are you going to give her? So a brief reminder now. This isn't a talk about IV fluids. I'm afraid this will be brief. But the reason I feel I can be brief is because, again, NICE in the last few years have published a fantastic document about how to give IV fluids in adults in hospital. And this will be the other document I would recommend you go read. But I am going to just summarize this very briefly. But I won't talk about special circumstances particularly. So let's talk about the different types of IV fluids. You've got blood products, so red blood cells, platelets, plasma, cryoprecipitate, albumin. You've got crystalloids, you've got balanced solutions, you've got normal saline. That's in inverted commas, and I'll come back to that in a minute. Dextrose, you've got bicarbonate. And then you've got colloids. Now, the colloids are the things that certainly I was taught in medical school, and people who are returning to practice after a few years may still remember about them. But actually, they've really gone out of fashion nowadays. We just don't use the colloids. Once upon a time, if you thought someone was shocked, you gave gelafusine. Now we give crystalloids. And the reason is because they're expensive. There's a risk of inducing anaphylaxis, and actually no one's ever shown they're actually any better than crystalloids, so we just use crystalloids. So for those of you who still remember the colloids, put them out of your mind. In the setting of acute general medicine, we just don't use them. So this is a table that's lifted out of the NICE guidelines, and it shows you what the composition of the different types of crystalloid are. Now, the one I want to just focus on for a minute is normal saline here, sodium chloride, and we've got plasma normal values here. Now, we call it normal saline, but actually that's a real misnomer because it's not normal. Let's just look at a few of the values. Sodium, 154. That makes it much higher than normal plasma. Chloride, same, much higher than normal plasma. There's no potassium, there's no bicarbonate, there's no magnesium, there's no glucose. And look at the pH, it's acidic compared to normal blood. And actually, one of the things we get referred sometimes in the renal world are people who have got an inexplicable metabolic acidosis. And actually, it's because they've been given sodium chloride, and it's inducing an acidosis. And actually, what I would just go back to is the sodium, 154. Now, if you do the maths, 154 millimoles per litre of sodium is 9 grams of sodium. And that is 35 packets of crisps. So that is not a small amount of sodium to give someone. So that is just something to really highlight that this is not normal. And so put that concept of, you can call it saline, you can call it sodium chloride, but please don't think of it as normal saline. This is not replacing like for like. And so actually to try and get around that problem, we have some of these other solutions over here. Hartmann's, lactated ringers, Plasma-Lite is another one. They're all variations on each other. You'll see they have slight variation, but what you see is they're generally a bit more physiological. They have some other salts in them. They've got less sodium. They've got appropriately less chloride. So generally, those would always be our preferred things. And people have tried to show that balanced solutions are better than saline, and there's the odd trial that has successfully done that. But actually, when you plug them into a meta-analysis, no one has clearly demonstrated that the balanced solution is better than saline, but it just seems logical that one is better. So when do we use them? So saline and balanced solutions, we would use those in generic hypovolemia, non-hemorrhagic hypovolemia. So someone's got diarrhea. Diarrhea is salt rich. You want to replace that salt, so you give them a balanced solution or saline back. Dextrose solution, as you probably remember, is 5% or 20% dextrose. You can get 10% as well. What happens is you infuse it, and the dextrose is rapidly metabolized by the liver, so you're left with free water. And it does provide a very small amount of calories, but a negligible amount that doesn't really achieve any nutritional benefit. Some people have heard about sodium bicarbonate. Occasionally in the ICU and the renal world, we use it. You find it in a strong form and a weak form. It's an intravenous fluid. The 8.4% must be given by a CVC. It's highly alkaline, which means it's very caustic to veins. You need to give it to a central line. The 1.26%, however, can be given peripherally. And in many ways, we give it as if you were giving saline. So they come in 500 ml bags. You can give it over a couple of hours or 4 hours or whatever you think is appropriate. It certainly corrects extracellular acidosis. And of course, as nephrologists, we worry about numbers and it makes us feel better. But actually, no one's really clearly demonstrated that's a good thing to do. And there is a theory that it may actually make the intracellular compartment more acidotic by causing shifts. And where it is particularly useful is for treating hyperkalemia in someone who's also dehydrated. So in this lady, actually bicarb would be an appropriate thing to give because she's dehydrated and she's hyperkalemic and she's presumably acidotic. The other reason why we have to be cautious about it is if someone has a respiratory compromise, so they've got horrendous pneumonia, they're profoundly fluid overloaded, arguably you wouldn't be giving fluids in that situation anyway, but they have to be able to get rid of the CO2 that's generated. And that's because if you remember this graph here, this is from medical school, when you give bicarbonate, it binds with the free acid. And then you see this movement, this shift in the equation, which generates water and it generates CO2. And that CO2 has to be blown off. So if someone's got respiratory compromise, you need to be careful when you give it because you could make a respiratory failure worse. But that's actually quite rare. I've never seen that truly happen. So I think actually that's something we worry about more than ever really truly occurs. So how do we go about giving IV fluids? Well, again, the NICE guidelines put it better as well as I could. In euvolemia, so when someone starts in a euvolemic state on the ward, they can't eat, for example, because they're vomiting or because there's something preventing them eating, they've got some sort of esophageal pathology. The guidelines say you should be giving 25 to 30 milliliters per kilogram per day of water and about 1 millimole per kilogram per day of potassium, sodium, and chloride, and a bit of glucose to limit starvation ketosis. And actually, that's quite a faff to remember. So really, you aim for 2 to 3 liters of IV fluid a day. If it's a smaller person, you give 2 liters. If it's a bigger person, you give 3 liters. And remember, if they're obese, don't calculate on that mils per kilogram because you're going to be drowning them in water. So you use their ideal body weight. And how we would do that practically is you'd use a litre of balanced solution, so a litre of plasma light over 8 hours perhaps, or 12 hours. Alternatively, you could use the saline dextrose, and then you'd use potassium supplemented dextrose after this. And if you remember, dextrose and saline, you can add either 20 or 40 millimoles of potassium to them to give them a bit more kick, as it were, from a potassium point of view. And you would give 1 or 2 liters of that again, and you just spread that over the course of the day. What you might do is you might give them as 2 8-hour bags, and then you might leave them for 8 hours overnight. And that's just simply so they're not peeing overnight and being woken up by drip stands and things going off. If they're hypovolemic, particularly if they're unstable, so if they're shocked, then the guidelines are very clear as well, that you give crystalloids and you give a bolus of 500 mils over less than 15 minutes. Actually, I would just put a little thing alongside that and say if you're worried that someone might have a poor heart, so this is a typical very frail 80-year-old, you think the heart might not be very good, you might give 250 milliliters rather than 500. And then, of course, the important thing is reassess. Give them the bolus, go away and do whatever you need to do, but you must come back after 15 minutes and reassess them. Otherwise, you haven't really done anything. You may need to give them more than 1 bolus. The guideline is consistent with what I've said. Don't use what's called tetrastarch, don't use colloids. Now, there's this thing at the bottom, like consider human albumin solution for fluid resuscitation. There's a theory that human albumin solution might bind the pathogenic cytokines in sepsis. Actually, you might see that being used in ICU, but we don't routinely use it on the wards. So really, your go-to thing if someone is shocked is going to be either saline or one of the balanced solutions. So let's go back to our lady. So you give her fluid, you get her blood pressure back to normal for her, but she remains oliguric. And by oliguric, I mean she's passing less than 0.5 milliliters per kilogram per hour of urine. And over the first 12 hours, she passes equivalent to about 5 milliliters per hour. And her creatinine's gone up on day 2. The question is, what's going on? And what are you going to do next? Well, she's probably got acute tubular necrosis. The other possibility you always bear in mind is, could she have an alternative diagnosis? So what are you going to do? Well, you're going to get some sort of imaging of her renal tract to make sure she's not obstructed. You're going to check her fluid balance, aiming to maintain euvolemia, and I will come back to that. You're going to treat any infections that are there. So, you know, if you think she might have an infection, you're going to treat it. You're going to stop her nephrotoxics, her ACE inhibitor, and so on. And you're also going to monitor her renal function. So let's just talk about pre-renal AKI, because that's what this lady probably has. So typically it's due to hypovolemia, but as I talked about, something else that causes, it's any cause of an effective drop in the blood pressure going to the kidneys. And that, for example, could be cardiogenic shock. So actually we can see it in the setting of someone who has a huge MI and they go into cardiogenic shock, and that's called a cardiorenal syndrome. But anything that drops the perfusion pressure in the kidneys. And that's because what happens is the kidneys can auto-regulate to a point. They can regulate their own blood pressure, but once your your mean arterial blood pressure drops below about 60 or 70, your kidneys lose the ability to maintain their own blood pressure, so your glomerular filtration rate drops. Drugs can make it worse, and I said I wasn't going to focus on drugs, but these are the big three I'd want you to take away and remember. ACE inhibitors, and that's of course ARBs as well nowadays, angiotensin receptor blockers, NSAIDs, and contrast. Radiological contrast, and actually it's the ones that we give for CT scans, iodinated contrast is the other one, and the other thing is renovascular disease. So the reason that renovascular means, renovascular disease simply means atherosclerosis in the vessels leading to the kidneys. So if someone's got evidence of atherosclerosis elsewhere, they've had a stroke, they've had a heart attack, they've probably got it in their renal vessels as well, and that means the blood pressure is already lower in the kidneys because there's less blood getting through. They typically have an elevated urea to creatinine ratio. So typically your urea is about 1/10 of your creatinine in health. So if you have creatinine about 70, your urea is often somewhere like 5 to 7. What you see is that changes when someone is got a pre-renal insult, and that's because the body uses urea to reabsorb water when it's hypovolemic. So the urea may be disproportionately elevated, and that's one of the clues about pre-renal. Now, what then happens is if you don't deal with that, if you don't treat that pre-renal injury, and what should happen is if you give fluid, that renal vasoconstriction goes away, the GFR goes back to normal. If that doesn't happen, that means that something else has happened. And so if in this lady's case, her creatinine continued to get worse, she remained oliguric even though you'd corrected the abnormal fluid state. And that's because she now has acute tubular necrosis. So that is when the tubules are no longer working effectively. Now, the reason why that happens is the tubules are one of the most metabolically active parts of the kidney. They exist in the semi-hypoxic state at the best of times, so they're prone to injury. And what happens is the urine goes brown because you start sloughing off bits of the kidney. And what happens is the urine actually goes very dilute initially. There may be not much of it, but it goes very dilute. And you see lots of sodium in it, and that's because the kidneys have lost the ability to reabsorb water and to reabsorb salts, because that's what the tubules do. So I want to stop at this moment, just one really important take-home message. Once a patient is roughly euvolemic, don't keep giving them IV fluids unless they can't take anything for themselves for some reason. And the reason is because there's no benefit. We get referred patient after patient who came in dry for some reason. They were given IV fluids. They reached a state of roughly euvolemia. Now, I say roughly because this is not an exact science. If their blood pressure looks okay, if their hands are warm, if their mucous membranes are okay, if they look like they're vaguely euvolemic, that is probably fine. There is no benefit in giving IV fluids. And what we see is people keep giving IV fluids, and actually they have an acute tubular necrosis, and no amount of IV fluid makes that better at that point. You just need to give it time. There's no evidence it shortens the AKI duration in general, and actually it might even make it longer because it increases your risk of sepsis, which then gives you a second AKI, but actually it probably drops your GFR by increasing the renal outflow pressures, the renal venous pressures. And actually people have shown, and this is a nice meta-analysis from a few years ago, that actually if you have AKI and you then get fluid overload, it increases your risk of mortality quite significantly. And there are very few meta-analyses. This is almost a pointless meta-analysis, and every trial has shown the same thing. So if you think someone's roughly euvolemic, please stop giving them fluid and just wait. Now, what about the alternative diagnosis part of this? Could she have an alternative diagnosis? As a nephrologist, what would be my key piece of information in considering a potential alternative? The urine dip. Now, when I was young and energetic, I put at the top, don't call a renal registrar without one. But actually, I'm a bit more of a cynical and realistic. renal registrar nowadays. And actually, sometimes it's just not feasible to get one. And I'd rather you called us and said, we're waiting for it, than you didn't call us because you're waiting and it's just not practical. So ideally get one, but if it's urgent, call us anyway and we can worry about the urine dip later. And it's more than just leukocytes and nitrites. The leukocytes are, of course, important. They tell us about inflammation in the kidney or the renal tract. Nitrites are important. They tell us about the prevalence of nitrate-producing bacteria. Proteinuria and hematuria are important from a renal point of view. Specific gravity is important because that tells us about concentrated defects. If you are dehydrated, but your urine is very dilute, that means the specific gravity is very low. It means that there's something wrong in your tubules. The pH can tell us if there's a problem with your renal tubules as well. And similarly, glucose tells us if there's a problem, or it tells us if you're diabetic as well, of course. So how do we interpret a urine dip in an AKI? So we refer to bland urine. That simply means the urine dip is negative. And that really, when you see a bland urine, that as a nephrologist means it's only one of two things. It's pre-renal, or it's progressed to ATN. It's obstruction, so it's something downstream of the kidney, or it's a tubular interstitial nephritis. Now, I had to put some slides in on that, but I've taken it out because I don't want to overwhelm you. Tubular interstitial nephritis is the great deceiver in the renal world. It's actually an intrinsic renal pathology, but it has a normal urine dip. That's something we tend to think about if AKIs aren't getting better, and that's a biopsy diagnosis. That's why people who don't get better tend to get renal biopsies, just to make sure we're not missing that. If they've got leukocytes and nitrites, job done, we've got a urinary tract infection. If they've got heavy protein in the setting of an AKI, that means they're nephrotic. And that means that we need to check their serum albumin, which will usually be low. And typically, it's not unusual for nephrotic syndrome to give someone an AKI in its own right. What it usually is they get a secondary acute tubular necrosis because all the fluid is in the wrong place. It's leaking out the kidneys, it's leaking out of the vessels into the legs and things, which means that their effective intravascular volume drops. If there's lots of blood and nothing else, that probably means they've got obstruction. It means there's a tumor or something. The other thing I would just warn you about is if someone has been catheterized, you can't really interpret that because the catheter itself will, of course, cause microscopic hematuria. If there's blood and protein, that's the opposite end of the spectrum. That is an active urine. And the reason why that's very important is because as a nephrologist, that's where we come in. An active urine sediment means it's a bleeding and leaking kidney. And the thing we worry about, the thing that gets nephrologists up in the middle of the night is if that's vasculitis, because that needs urgent management and won't get better without urgent treatment, which is usually immunosuppression. So really, that's just the spectrum. And the one on the right, if you see protein, you see blood, certainly more than 2+ on the dip, that's worth calling a nephrologist and just discussing it. Of course, with the proviso that it could be due to the catheter, but let us make that call rather than you. Of course, the difficulty arises if there's multiple comorbidities. So if someone already has, for example, diabetic nephropathy, they may have blood and protein at the best of times. So how do you interpret another insult on top of that? That can create a problem. And what you sometimes see is just a little bit of blood and protein. So maybe 1+ blood, 1+ protein in bland urine. And that's because actually the kidneys are injured, which means they do leak a bit of blood and protein. So a little bit of blood and protein doesn't necessarily change our opinion on things. So what do we do if we think someone might have vasculitis? We do a whole long list of bloods. Now we'll talk you through them over the phone if you ever need them, but let's just quickly talk about why we do them. ANCA tells us if someone might have an ANCA vasculitis. The anti-nuclear antibody may diagnose lupus, Sjögren's, scleroderma. Don't worry, you don't need to remember all these things. I'm just telling you why we're doing them. Anti-GBM is the thing that people tend to remember the best of renal disease. Anti-GBM disease is good pastures. And that tends to present with hematuria in the kidneys, but actually they often present with hemoptysis as well. They're coughing up blood as well. And that's attacking the glomerular basement membrane that's also present in the lungs. Immunoglobulins, and that's for myeloma. Similarly with the serum protein electrophoresis. We look at complements, and that's for cryoglobulinemia, lupus. Actually, endocarditis gives you low complements and can also give you an AKI. Rheumatoid factor, again, cryoglobulinemia. And then in other settings, we may look at some other things. So we may look at HIV and hepatitis B and C serology. We may think about cryoglobulins, blood films, if we think someone's hemolyzing. And then in the urine, we'd always send a protein creatinine ratio. Are they leaking protein? And we'd also send a Bence-Jones protein, which is also referred to as protein electrophoresis. And that's looking for evidence of that leaking protein in myeloma leaking out in the urine. Right, so let's move on to case 2. seen in the A&E department, 84-year-old man, usually fit and well. He's got a bit of past medical history, takes some medications. He's admitted with fevers and increasing confusion. He's brought by his daughter, who's been staying with him. He's been incontinent for the last couple of days, and obviously he's pyrexial. He doesn't know where he is or what's going on. He's a bit dry clinically. He's got a bit of tachycardia and he's pyrexial. He's tender suprapubically, and his blood show a creatinine of 400. I can't remember if I told you a baseline. Let's assume, oh yes it is, his creatinine was normal in 2016. He's got a potassium of 6.5 and he's got a metabolic acidosis. And the reason we know he has a metabolic acidosis is he has a pH of less than 7.3 and he has a low bicarb. So bicarb usually is 23 and upwards, 23 to 30. He has a low bicarb and a low pH. He has a metabolic acidosis. And he has a bladder scan done by A&E which shows over a litre. Generally, it's not normal to have more than about 300 mils in your bladder. And actually the best way to test that is get someone to go pee first and then do the bladder scan, and it should be somewhere near empty. But he has over a litre. So what's his differential diagnosis? Well, he's probably septic, he's tachycardic, he's pyrexial, he's confused, so he's not perfusing his brain, we assume. So that's a pre-renal hit. He could be obstructed. We know he's got a litre in his bladder. And of course, there's always this tubal interstitial nephritis that's the great pretender. How are we going to manage this? Well, firstly, it goes back to ABC. Firstly, we're going to get his blood pressure. We're going to stabilize him hemodynamically. The thing that's going to kill him first will be his hyperkalemia. And so we're going to treat the high potassium. I haven't talked about ECG changes because I know that Jamie's just talked about that, but we're going to treat the high potassium. And that's going to be with insulin dextrose. It's going to be with calcium gluconate. Again, every trust has a slightly different protocol. I would suggest you read your own AKI guidelines for how to manage that. But as a rule of thumb, you give insulin and dextrose and you give calcium gluconate. The calcium gluconate stabilizes the heart, stops arrhythmias. The insulin dextrose drives the potassium back into cells. And that will work for about 4 hours. You do a bladder scan, which you've already done. He's going to get a catheter. You do a urine dip, but of course in him it's very difficult because he's got a catheter now. But what you can see is he's got leukocytes and nitrites, so he's got an infection in his bladder as well. You're going to, of course, do blood and urine cultures like you would for anyone who was septic. You're going to give him some intravenous fluids, and you're going to try and stabilize him, and you're going to give him some IV antibiotics. And you're going to urgently want to image his renal tract. Now, when I say urgent, the reason why it's important with him, we're going to come on to in a minute, but actually in someone who wasn't pyrexial, the following day would be perfectly acceptable if it was middle of the night. But in him, it's slightly different. So the repeat blood's the following day. His creatinine's now halved, his potassium's got better, and his ultrasound shows moderate hydronephrosis and an enlarged prostate. So his diagnosis was an obstructive AKI, a post-renal AKI. And the management is simply to relieve the obstruction, let the urine flow. So that might be a catheter. If there was concern, you would then, and it showed the kidneys were blocked and actually the bladder wasn't draining anything, so the blockage was higher up, you might put a nephrostomy in to relieve the urine directly out of the kidney, or you may put a stent in which opens up the ureter past any blockage. The reason why I mentioned he is a bit different and you'd want to get imaging in the middle of the night, and that will probably be a CT scan usually, is because if you suspect someone has an obstructed and infected renal tract, that is a urological emergency. So if someone has an infected, obstructed kidney, that needs dealing with even if it's 3 a.m. So that is why if someone is pyrexial and you think they may be obstructed, you should push for a CT scan. And actually most trusts won't argue with that nowadays. So all is good, he's getting better, but 2 days later, you're asked to review his bloods by your junior. His creatinine has now gone back up to 500. So it got better, now it's got worse again. What are you going to do next? Well, you're going to do the obvious stuff. You're going to go see him. You're going to see what's going on. You're going to look at his drug chart, make sure no one started him on any nephrotoxic medications, and you're going to make sure that the catheter is not blocked or anything like that, but you hope the nurses would have done that first. You go see him, he's complaining he feels very thirsty, he's a bit hypotensive, his hands feel cool, and he's got an empty water jug at his bedside. And you have a look at his urine output. And what you see is he's drunk about 400 mils, but actually he's peed a lot more than that. Now, actually, that urine output is pretty normal. Someone like me probably pees like that. But the thing in him is it's important to look at the context. He is dry, remember, clinically, and yet he's peeing well over 100 mils an hour. What's actually happened in him is he's developed a post-obstructive diuresis. And this is the important thing to remember about these people. And it's why if someone was particularly old and frail, even though you put the catheter in, you'd probably keep them overnight just to keep an eye on, because you don't want this to happen. And what happens is you relieve the obstructed kidneys and the body just pours out water and salt. That might be physiological if the patient's become very overloaded. We don't know how common it is. Various studies have said anywhere between 0.5 and 50% of relieved obstructions. And what we think is, whilst there is probably a degree of a physiological response to sorting out your fluid balance, actually there's probably a pathology there as well, where you've damaged your collecting ducts, which creates a transient diabetes insipidus. You may lose the ability to concentrate the urine temporarily in the loop of Henle, or there may be something happening higher up in the kidney's feedback mechanisms. The way you'd manage it is you replace the losses. So if someone is peeing too much, you need to give them that fluid back. This does get better. This usually over a few days, this will get better. But it's important that during that time, they don't get a second AKI because they get dehydrated, because it will prolong their recovery. And so the way you do that is you replace the losses back to a point of euvolemia. So in him, you'd have to play a bit of catch up. But once you think you're roughly euvolemic, you aim to replace the losses to a degree. So you, for example, aim to replace 75% of the previous hour's losses. The problem is that's quite work heavy on the nurses. So sometimes what you do is you give fairly copious fluid, then you'll give the patient a rest for 6 hours and see what happens to their urine output. And if the urine output appropriately drops, then you can say it's resolved. If it hasn't, if it keeps going, you give the fluid, continue with the fluid. And because, as you can imagine, you could end up in a situation where you are giving fluid and they're peeing it out. So you're giving more fluid and they're peeing it out. So the key is that you don't give them back the same amount that they've peed out, so that situation doesn't happen. You give them a bit less. So despite the catch-up fluids, this renal function gets worse. The creatinine is now 800 and the urea is 45. The potassium's gone up at 6.5. You've given them lots of insulin dextrose. It hasn't got better. The patient's becoming confused and seems a bit twitchy. And one of the nurses said to you, could he be uremic? What should we do now? So let's just talk about uremia. What are the symptoms and signs? Well, often the first thing the patient will complain of is just feeling very lethargic, and they may develop a headache. And over time, if you continue to ignore that, they become drowsy, they become confused, and eventually they may start to have seizures. Well, I hope you would have picked it up before then. The thing that you look for, which is the sign for this, is the uremic flap. That tends to appear somewhere between the headache and the drowsiness and confusion stage, about there. And so if you remember, the flap is you get them to put their hands up as if they were leaning against a wall, and you see the twitching, the distinctive twitching of the fingers. They may complain just feeling washed out. If they complain of chest pain, you should listen for a pericardial rub and do an ECG, because that could be signs of a uremic pericarditis. They may start vomiting, and they may develop rancid smelling breath, and that's called a uremic fetor. What I would say is that uremia is generally not seen if a patient who's regularly on dialysis misses a dialysis session or is due to go on dialysis. We quite regularly get referred our dialysis patients. They've missed a session because they've been unwell, or they come in confused, and the assumption is that they're uremic because they're due dialysis. That is not the case. Missing one dialysis session does not make you uremic, and similarly, you do not become uremic between dialysis sessions. And generally, as a rule, it's not an absolute rule, but as a rule, as a sort of guideline, if your serum urea is less than 30, it's very unlikely that you're uremic. There's usually another explanation for any confusion. It's the confusion bit that tends to confuse people the most when someone's got an AKI. So what does this person need? They need dialysis. And what would be the indications? I've put HD here for hemodialysis. What would be the indications for acute hemodialysis? Well, again, these haven't really changed since you were probably in medical school. It's refractory hyperkalemia. So if you're generally a potassium greater than 6, and that's despite repeated medical treatment. If someone is now in pulmonary edema and they're oliguric, they're not passing much urine, because that means we can't give them diuretics to try and get rid of the fluid. If they're severely acidotic, and that generally means a blood pH of less than 7.1 or 7.2, and the only absolute indication really in that situation is the uremic pericarditis and encephalopathy. So if someone is truly encephalopathic or has a uremic pericarditis, they are absolute indications for renal replacement therapy. So that's what AKI is. And the question, of course, is when should you call us? When do you need to call the nephrologist? Do we need to know about every AKI? Well, the answer is no, we don't need to know about every AKI. We'd be overwhelmed. But which ones do we want to know about? Now, this is just common sense, really. This is a nice guideline. It's a long list of reasons, but actually they're really all common sense. So if you think there may be something going wrong with the kidney itself, so vasculitis, you think they've got myeloma for some other reason, so that needs renal specific input. If you can't work out why they've got an AKI, if they're not getting better, if they're developing complications, so fluid overload, hyperkalemia, if it's severe AKI, if they've got a renal transplant, we're very protective of our renal transplant patients and we like to know if they've got an AKI, even if you're otherwise happy managing it. And if they've already got quite severe renal impairment. And that's because actually they don't need to get that severe an AKI before they need dialysis. So hopefully that's all common sense stuff, because they're generally going to be situations where you are going to be out of your depth. And so actually probably the best time when to call the experts is if you're in doubt and you don't know what to do. And as a general rule, we'd rather know about a case early, give you some advice over the phone, and they just get better, than you call us at 5 o'clock on Friday telling us they need dialysis and they've been in hospital for a week. So actually, if in doubt, let us know. We'll give you some advice. We always keep a little watch list of patients to keep an eye out on their blood tests and things. If they get better, we'll just take them off it. If they're getting worse, we know about them so we can come see them. So I just want to quickly talk about AKI and coronavirus, just because it's the topic of the month, of course. What I would say is this is a very brief summary and it's an evolving situation. If you are interested in this, there's something called the Nephrology Journal Club, NEPHJC, and they have created a fantastic webpage which they're keeping up to date on a day-to-day basis on our understanding of coronavirus and the kidneys. As if you're really interested in this, go and have a read there, and it's written in a very approachable way. It's fantastic. But the picture is not quite clear at the moment about what's going on in coronavirus in the kidneys. What we do know is that there are certainly a subset who come in with a severe AKI. The problem is these studies are all observational. People haven't corrected, for example, pre-existing renal impairment. So what we don't know is whether it's just simply someone who's got a severe AKI and actually they had CKD anyway, or whether this is a completely new AKI. But one Chinese study did find that half of patients had proteinuria and hematuria on admission. Where's my mouse? Had hematuria on admission, and actually that frequency of AKI probably goes up in those who are critically unwell. Like all diseases, we know that if you have an AKI, it's associated with increased mortality. Now, what we don't know is whether the coronavirus is directly infecting the kidneys, and there is some evidence to suggest it infects the tubules, or whether it is simply these patients are just really sick for other reasons, and like all people who are very, very sick, they often get an AKI as well. That is not clear at the moment. So how do we manage an AKI in the setting of coronavirus? So we aim to avoid fluid overload and actually try to keep them on the slightly dry side. And that's because if they do develop this sort of feared ARDS, the thing that is sending people to intensive care at the moment, if they get that and they're fluid overloaded at the same time, that is really bad for patients. So we try to avoid them becoming overloaded. And if that means them being a bit dry, then that is fine. And so what you do is you give small amounts of fluid if you need to. And you try to give very slow rates of maintenance fluid if you need to give maintenance fluid. And like I say, that's because we're trying to run them slightly dry. And there's no reason why they can't have renal replacement therapy if needed. So to all other intents and purposes, they're managed as an AKI like anywhere else. But it's just that you should probably try and keep them on the dry side rather than aiming for euvolemia. And please don't let them get fluid overloaded. So take-home messages. How do we manage AKI on the medical take? You do a fluid balance assessment and you assess their fluid state and you keep assessing their fluid balance. Get the nurses to monitor their urine output, catheterize them if you need to. Treat the pre-renal AKI if it's present, so give them fluids, but once they're euvolemic, don't keep giving them. Exclude obstruction, so do an ultrasound, do a bladder scan, put a catheter in, do a urine dip, and monitor for evidence of recovery or deterioration. And remember those indications for renal replacement therapy and AKI. And if they're heading that way, you think they might be starting to get there, please call us. And do daily bloods, including a serum bicarbonate, which you can request on lab bloods. It saves you having to do a venous blood gas every day, and a potassium. And of course, if you're unsure, please give us a call. Believe it or not, we're actually a very friendly bunch as nephrologists, and we're very happy to give advice over the phone. And I'm going to stop there.
Thank you very much, Matt, for that really informative session. And I'm sure we all appreciate how friendly you are, if you're so friendly on the phone as you are speaking to us now.
Thank you.
There was a few questions which you managed to answer during the sessions. There was just one which I wanted to cover, which was in your patient who had case 2 who
Yes.
we found that they had an obstruction, which was relieved. But if you thought it was a lower urinary tract obstruction with an infection as the cause, do you still need that urgent overnight imaging?
So no, in that situation with the bladder scan, it's probably reasonable to you've relieved the obstruction with the catheter, and it's probably reasonable to just watch and wait overnight and see what happens. But if they were deteriorating, they were getting worse, then yes, absolutely, you do the CT overnight, because you don't know whether you may be seeing a litre of urine in the bladder, but the kidneys may also be obstructed as well. There may be 2 pathologies. But generally, if it is an obstructed infected system, and a bit like draining an abscess, and you then drain the infection, the patient starts to improve.
Thank you very much.